What's up, Doc Mike? Public Health on Call. By Johns Hopkins Bloomberg School of Public Health. Today's topic for April 11, 2021. George Benjamin on mending the broken system. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, the producer of Public Health on Call. The theme of this year's National Public Health Week is Building Bridges to Better Health. Dr. George Benjamin, president of the American Public Health Association, talks today with Dr. Josh Sharfstein about the poor condition of these bridges, from archaic lab technology and a sparse workforce to gross inequities in healthcare. They discuss what needs to be done to fix the system so these inequities and current and potential health threats can be addressed to save lives. Let's listen.
Dr. Benjamin, it's great to have you back on the Public Health on Call podcast and during National Public Health Week.
Josh, I'm glad to be here. Thanks for having me again.
So the theme for National Public Health Week is building bridges to better health. And I guess I want to start with the concept of a bridge and what condition are our bridges to better health in right now as we're talking in April 2021?
You know, one of the challenges that COVID-19 has exposed is the fact that both ends of our bridge in public health are very fragile. If you think about all of the public health activities and threats that we've had over the last several years, we really haven't done as well as the science says we could have done. You know, the opioid epidemic, lots of red flags were missed throughout the whole health system. Opioids, obesity, we made inroads, but just as we were making inroads, of course, it's like everything else, it kind of flattened out and then it stopped. If you really go back and look at some of the other infectious disease outbreaks, Zika, we really had to rebuild, and by the way, we never really did rebuild it, our mosquito control programs. And so I think what COVID has done is really showed us how broke the system really is and how much work we have to do of both building, as we kind of metaphorically say, the anchors of both of those bridges, and then building that bridge into the future to have the public health system that we all know that the public deserves and we really need.
So let me ask you just a few of the specifics kind of quickly here, but lab capacity. Do we have an issue with lab capacity in terms of the infrastructure of public health?
We have a nice lab system, but it's still archaic. For example, we have not invested in the kind of lab capacity that has the modern genetic systems so that we can do the kind of disease surveillance that we know is capacity for both bacteria or viruses.
Yeah. What about the workforce in public health? There's been a decline in the workforce. How would you characterize the state of the workforce?
Well, we've lost over 50,000 jobs over the last 10 years. And people say that we probably need at least 100,000 new jobs overall because we're already in a deficit. But by the way, we don't need 50 or 100,000 of the old jobs we had. We need to have a new set of jobs that will have the skill set to go into the future, particularly like laboratories. The genetic science that the old laboratorians use is very different than what the new laboratorians need. The surveillance systems, we're still doing contact tracing and the old way, banging on doors, talking to people. We need to figure out how we modernize contact tracing in a world where we can do crowdsourcing and electronic surveillance and things like that, and notifying people quite differently in the future than we've done in the past.
Then there's also the data systems. And, one of the big challenges now is that there's very little data on some issues with respect to equity, even though we realize it's such a big challenge.
I used to give a talk to organizations about antiquated systems, and I would use dinosaurs and carbon paper and fax machines. Well, it turns out that I was wrong about fax machines, since a fair number of our local health departments are moving data around by fax machines. They're filling them out with the pen and paper, and the systems are just, not up to the kind of technology that we know exists today.
So let's transition to imagining, fixing this bridge, getting to a place where we can do a lot better in preventing illness and keeping people healthy. What does that public health system look like?
It's a system that there's a no wrong door philosophy. No matter where a health threat enters the system, whether it's through the public health system, whether it's through an astute occlusion, whether it is through some data system that some research is analyzing for some other purpose, that health threat can be rapidly identified, analyzed, and then a plan put in place to address it. And we don't have that system yet. That requires modernized workforce, modernized data systems. That requires the ability to be able to deduplicate data so that we know that we're talking about patient A versus patient B. And that requires sitting back with a white sheet of paper and saying, okay, if we were going to design the system, what would it look like? What would the data systems look like? What would the workforce look like? And then let's project that 10 years ahead. And then how do we build that system for the future so that we're constantly investing in improvements through a total quality improvement process to get to the idealized system that we know that we deserve and need.
So COVID, as you've pointed out, has really exposed the gaps in our current system. And at the same time, some of the responses to COVID, and most recently the American Rescue Plan, actually aims to close some of those gaps. And you have, for the first time, a major investment in the public health workforce. There is, I think, $500 million for CDC's data modernization initiative. How much do you think is going to change as a result of what's passed so far?
Well, let me say that the potential is enormous to have substantial change. It is one-time money, though, and spending money thoughtfully and appropriately over the 2-year window in effect that we have will not be easy. And we're behind the curve already in terms of trying to design the blueprint that we need. And then we're going to have to make a long-term investment, which is somewhere between $4.5 and $7 billion annually, to increase the base of public health funding and actually to be able to have it to be sustainable. Because I think that one of the things that we also have to build in that blueprint is the rift that we saw in equity. We knew that inequities existed. Those health inequities have been there for years. We knew about them, but there's no one now who can say that they didn't know about it. And so this system also has to be designed in a way to not just do things where we used to do them, but to actually close those inequities and improve health for all at the same time. Because there's two ways to close inequities. You can bring the health status of the people that are most benefited down, or you can bring the people who are least benefited up, or you can close that gap and increase the health improvement for everyone. And of course, that's the method that we want. We want to improve the health for everyone as well as closing those gaps.
So in the United States, that's a complicated endeavor because we have the federal government, we have state governments, we have local governments, we have different, governing bodies for each of them. We've seen the patchwork that exists with COVID. How do you imagine that consistent progress to close the gaps in our public health system could happen in this country?
It's going to take profound leadership, focus, and thoughtfulness. And we have a health secretary who's very thoughtful, but he's going to, of course, need to provide the leadership for us to get there. And we in the public health community, non-governmental public health community, are going to have to provide an awful lot of leadership because we have an administration that's willing to partner with us. We have good, solid leaders in that administration, and we're going to have to find ways to partner with them thoughtfully. And, there's 2 or 3 coalitions out there that have already been designed that can basically refocus their efforts once we get COVID under control to once and for all building the public health infrastructure. as you know, we've got enormous blueprints out there. We just haven't ever put them all together.
Now, some people have suggested that one way that this might come together is for the federal government to put funding on the table and say, here's our expectation for you as a local health department, you as a state health department. And if you're able to meet it, then you can get the extra funding. And basically use the federal government's power to fund to drive change to the system, because you can't just have it as a dictate necessarily from Washington in a federal system like we have, where a lot of the authority rests with states.
I think that's where we have to do that. And, of course, in Maryland, we have that model, right, with the core funding model that we have for local health departments. But it does require goodwill. It does require consensus. And if we do it in a way where states feel that states' rights are being overly violated, we won't get anywhere. And so it's going to require the federal government to sit down with the governors in particular, and then mayors, and coming to some agreement that our public health system is truly broke. We all know that, but they have to agree to it. And then they have to say, okay, how do we jointly fund this project in a way that makes sense? And here are the things we think that are in the best interest of our nation. And then here's the matching funds you need to put up for that. So that, because, I'm concerned about once the feds put money on the table, the locals pulling that money away and letting it be supplanted. And we need to do it very much like the Medicaid model in many ways, or the model we have in Maryland for core funding, where the states can put, the feds, the state puts up money and the locals match it, or the feds put up money and the states match it. And then we need to, come up with the formula for each state, but it's going to take some work to do that.
And what would you say if you were invited to talk at that meeting with the White House secretary and the governors? What would you say is at stake in that discussion?
I think the health and well-being of Americans is at stake. It's no longer that we simply aren't going to get as healthy as we want to be as fast as we could be. I think that lives are at stake each and every day. And we see that with COVID. We're going to approach almost 600,000 deaths with this terrible COVID outbreak. We are no longer paying as much attention as we need to on the firearm-related deaths. We've kind of put aside the suicides, which are still occurring at record numbers in our community. We have people who are still dying of a whole range of chronic disease, heart disease, lung disease. Tobacco is still the leading preventable cause of death from a chronic disease perspective. And we're not really playing as much globally as we need to. We're not going to make sure everybody's healthy unless we really look at this from a global perspective as well. So it's going to take, I'm going to be advocating, if they let me in the room, for a strong partnership, a well-defined partnership between the federal, state, and local government, which codifies our legislative authority. Because as you and I have talked about often, how people really don't understand the public health authorities. We need to make sure people understand that. And we need to make sure that the money and the programs and the goals are all in alignment.
Well, Dr. Benjamin, thank you so much for your leadership and congratulations on a successful end to National Public Health Week.
Josh, thank you. I look forward to our future working together, and this has been a great week.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.